So guys, I can promise you this is very unique opportunity to really get answers straight from some of the experts. We have a powerhouse here. Please use this opportunity to ask questions. Without going too much into case-specific questions, you can certainly grab these folks and talk to them, but in general questions. So while we are collecting questions, why don't I get started and throw the first question to Susan, since this is a breakout session focusing on high grades, and you probably talked to hundreds of patients over the past decade on high-grade patients. What are the challenges that you incur in kind of navigating the process? What are the top 2 or 3 problems that high-grade neuroendocrine cancer patients kind of suffer, and what is your usual advice to them?
Well, I think the urgency is my favorite word when I'm talking about this, because 90% of all the oncologists, and you guys know this, do not understand how urgent it is. You know, patients will be told, they get the diagnosis, they're told, we don't have a chemo chair for you available, 6 weeks down the road. And when they find me, when they come to Facebook or social media and they get into the group, that is what we do. We teach them advocacy. We teach them that they need to just to do this and pay attention to the information we're giving them in the group, because they're not getting the information elsewhere. And there are many other net groups out there, and a lot of people get stuck in there. They do not find us. They do not understand how important it is to get to one of you guys as soon as possible.
Very well said, and I agree. We all have seen patients who have been thought that they have slow-growing neuroendocrine cancer, and while the tumor grew pretty fast. Just FYI, small cell cancer, the tumor doubling time can be as small as 14 days. So while you're waiting post-biopsy, seeing a provider, you can have substantial growth in your cancer, upstaging of cancer, or worsening of disease. So urgency is the key point here. And I'm glad that Marianne, thank you for providing us this opportunity so we can educate not only you, but you can go ahead and educate the further community that high-grade neuroendocrine cancer is not like our low-grade NETs, needs a little bit of urgency. Wonderful. All right.
Wait, I have a question over here.
Hi, my name is Mark Travis. I'm from Corpus Christi, Texas. Just wanted to ask, speaking to that point and also to clinical trials in terms of the urgency, a lot of the trials that we've heard about or been offered have a washout period, generally up to a month of time. Given the urgency and the need for treatment, it seems a little daunting to have that much dormant time without treatment. When you're designing trials, to keep that in mind, or and on the patient side, is it something worth taking the risk of going those 28 days to get to the finish line and to actually start the trial?
I think that's a great point. And we have now slowly but surely started incorporating patient views during the trial design phase itself. I think we need to do better. You're absolutely right, especially with regards to high-grade neuroendocrine cancer trials, where we don't really have that luxury to expect long washout periods, and because of the urgency of the situation. But your point is well taken, and that's where the art of medicine lies. The clinical trial, there might be a great clinical trial, but if it necessitates a biopsy and a pre-screening, and while my patient is progressing, then despite having a good trial option, that's not the tight time for that patient at that point of time. So we might have to stabilize the disease with the next best alternative or a standard therapy. Dr. Halfdanarson, you see a lot of high-grade patients, Mayo. Any comment on that aspect of disease?
No, I think it's a great point, and hopefully and I absolutely understand the importance of this and the stress associated with waiting for a drug to wash out. So truth be told, most of these drugs are gone out of your system within days, and the side effects have resolved within a week or two for most part. So I think we need to be mindful of this in future trial designs for this patient cohort. Get away, eliminate that long washout period. I think that's what's needed.
Absolutely. Sometimes when we are designing these studies, they're done with very scientific rationale, very clean data, but they sometimes forget the practical aspect of things. So very nicely pointed out. I have some wonderful questions for low-grade nets. I will hang on to them because we're going to bore you to death in next 2 days about low-grade, and there'll be plenty of Q&A sections, so we will go over those. So don't feel that I ignored them, but I'm kind of reserving some of those for our subsequent sessions. This is a good one. Is clinicaltrial.gov the only place to get clinical trial info? Dr. Starr, do you want to comment? And Susan, you can chime in.
Yeah, the clinicaltrial.gov is not the most user-friendly site. It can be really difficult and daunting to navigate, even as an oncologist who's been using it for many years now. There are some organizations out there that help kind of procure some clinical trials that are specific to your situation. NCAN obviously could be a resource to help search clinical trials. I've been using an organization called Cancer Commons, and they have PhDs and medical folks who are actually looking for clinical trials for you specific to your situation. And I'll also Dr. Halfdanarson and I were just talking about this. I'll give a shout out. Nanets is working on developing a clinical trial app specific for neuroendocrine neoplasms, neuroendocrine cancers, that will help navigate and help that process, and very specific, like what is your key 67, right? Because not only is it difficult to find a clinical trial, you find one, and then the eligibility criteria are, a laundry list, and so I don't know what some of this means. So clinicaltrials.gov is nice in that it's central, but there are some organizations, and we are working on some options to make this easier, and less daunting. I will sometimes have my patient come in for a visit where we will specifically search clinical trials, right? Because it takes a while, so I have to kind of reserve dedicated time to do that. But I'm willing to do that, and I do that.
There are also, most of you guys know Josh Mailman. He has a new venture with a company, is it Anco or?
Ancora.
Ancora, okay. I have the code at my table. It's amazing, especially for high grades. You scan it, you plug in all your name, your information, where you live, what your diagnosis is, your Ki-67, all of that, and it pops up all kinds of things where you live, located close to you. So that's a game changer, I think, after trying to navigate
Wonderful.
clinicaltrials.gov.
Thank you, Susan. So we don't want to hold people here for too long because you guys deserve a break, but we also have a lot of really good questions. What I'll do is I will wrap up the session with one final question, and then hold on to all these questions because we will have these lovely panelists and speakers for the rest of the meeting as well, and try to address some of these questions. So Dr. Ramirez, final question to you. So this is a patient who has high-grade, I think poorly differentiated neuroendocrine cancer, but no known primary. So we don't know where the primary is. Would we ever find a primary, or does it matter? And what are some of the tools that we might use to find primary?
So yeah, this is a scenario that comes up from time to time where someone will come in for whatever, various symptoms, and a scan shows metastatic disease to the liver or elsewhere, and we do a biopsy, and the pathologist says this is a neuroendocrine neoplasm or a neuroendocrine carcinoma. But we don't have, on the scans, we say, all right, well, where did it start? It didn't start in the liver. Tumors normally don't start there. They travel there, and certainly, if it's in a bone or so, it didn't start there. But many times, a lot of times we say, all right, well, there's a lung mass. Well, all right, there's your primary. Or there's a pancreas mass. There's your primary. But every now and again, we get this, well, we don't necessarily have a primary. And so sometimes it matters where the primary location is, and sometimes it doesn't. There are certain tests that we can do to kind of tell us where the primary is. There's certain tumor markers that we look at that can sometimes tell us. Sometimes there's different genomic tests that we can do, and there's a couple different companies that do this. Some are better than others, but especially in a neuroendocrine carcinoma, we talked about how time is of the essence. So at that, when I have that patient who comes in and their liver is 50% replaced with tumor, I don't have time to find out, well, send this test and find out where the primary is. I'm going to treat this patient with whatever I think the best option would be. And if it's a neuroendocrine carcinoma with a high Key 67, I learned that today. So, that patient is probably getting platinum. And the good thing about that is platinum is given once every 3 weeks, and after 2 cycles, I know if it's going to work or not. And if it's not going to work, well, then I switch to something different right away. So then I'll use I'll use a 5FU based regimen. And maybe I can get some tumor control that way. So sometimes it matters where the primary is located. Other times it doesn't.
Summarizing that, and again, I'm sorry, we have a lot of really good questions, but I assure you guys that we will have tons of opportunities. I think you guys deserve a little break. So please, a big round of applause to all our speakers and to you guys for being wonderful listeners.